Hello, my name is Valerie Connor, and my case study is going to be on Hodgkin's lymphoma. History of the illness for my patient, we'll call him CBD. He is a 61-year-old married male with history of Hodgkin's lymphoma. Patient, he's been a forklift driver for 40 years. It's the only job he's ever had. He was originally diagnosed in 2010 with stage 4 with liver, spleen, and lung involvement. He received 6 cycles of ABVD, that's adriamycin, bleomycin, vinblastine, and dacarbazine. And then after that, he had his PET scan, and it was determined that he was in complete remission, which lasted until November of 2016, so about 6 years he was in remission, and he was found to have relapsed. So he received another 6 cycles of the ABVD, although after a first relapse you would typically not go back and do the same regimen. It would have been suggested at that time to do high-dose chemo and do an autologous transplant. But the patient wanted to try to do the regimen again and see how long it would last. So he did. He finished in April of last year, and he went into a remission for all of about 6 months before he relapsed again. And so at that time, he decided that it would be okay to go ahead and go with the high-dose chemo and the transplant. So that's what he did. He came in and he did 3 cycles of ICE, which is ifosfamide, carboplatin, and etoposide. He did 3 cycles of that. He finished in January, and then he came in for his, that's his salvage chemo, and then he came in for his high-dose chemo and his transplant. So when I had him this past weekend, he was day +4, which means his transplant is day 0. And so every day after that, you just add a day. So he was 4 days out from his transplant when I had him this weekend, and really actually doing pretty well with his physical exam. His skin was fine, no rashes, no lesions, no skin color changes. He's bald, so we didn't have any issues with hair falling out. And then no nail changes. He had no vision, no hearing changes, no complaints of pain, no drainage from his eyes or nose, no mouth ulcers, which is sometimes common with chemotherapy to get mucositis, just sores in your mouth, no swallowing complaints. As far as respiratory goes, no shortness of air, no cough, no trouble breathing. His lungs were clear. Cardiovascular-wise, no palpitations, regular pulse, sinus rhythm. Gastrointestinal has been an issue, which it usually is with most of our cancer patients, because typically chemotherapy is going to make somebody nauseous and make it hard for them to eat. So he has been experiencing some mild nausea, but they've scheduled Zofran every 6 hours, and that's been keeping things at bay and allowing him to eat. Not a lot, but a little bit throughout the day, enough. He did start having diarrhea on his day +3, so they had sent the sample to the lab. We were waiting results, but it didn't look like there was any blood in his stool, no abdominal pain. He wasn't distended, his abdomen was soft. Genitourinary, no dysuria, no incontinence, no hematuria, no increase in frequency, no hesitation. Musculoskeletal, he had no arthralgias, no myalgias, no swelling, no inflammation, normal range of motion. Circulatory system, good pulses, no edema in his extremities, no calf tenderness. Neurologic-wise, no headaches, no dizziness, no syncope, no balance changes, no fine motor issues. He had already had a history of peripheral neuropathy on arrival from previous chemo regimens. EMV 15, oriented ×4, hematologic, no bleeding, no bruising, no petechiae. As far as endocrine, no hot or cold intolerance, no sweating or increased thirst. Psych-wise, no anxiety, no depression, and actually has a really amazing attitude. very hopeful, and I'm hopeful for him. As far as past medical history, obviously the Hodgkin's lymphoma, since it was diagnosed in 2010. Dyslipidemia, hypertension, type 2 diabetes, congestive heart failure, which occurred after his second round of the ABVD chemo regimen. He's had gallstones and, of course, the chemo-induced peripheral neuropathy, and his only surgery was an abdominal hernia repair, not recent. His medications, metformin, glimepiride, pioglitazone, Coreg, lisinopril, Lasix, and vitamin B complex. As far as family history, he had a sister who had throat cancer who also developed leukemia after her cancer treatment and passed away from that. He has another sister and brother who both have histories of CAD, coronary artery disease. His mother passed away and had a history of CHF, and his father also passed away, had a history of CHF and pancreatic cancer. The patient is married and has 3 healthy adult children. As far as pathophysiology, Hodgkin's lymphoma starts with an abnormal B-cell lymphocyte in the immune system. And since there's lymph tissue all over your body, it can basically start anywhere. The Hodgkin's lymphoma cells are called Reed-Sternberg cells. And they don't go through, the normal cell death like they should. Instead, they enlarge and they spread through the body. Hodgkin's lymphoma is idiopathic. They have risk factors that may increase your chances, but they really don't know what causes it. Some risk factors that might increase your chance of getting Hodgkin's lymphoma is the Epstein-Barr virus, or just really viruses in general. Epstein-Barr, HIV, I think TB is a risk factor, and just a weakened immune system can increase your risk. If there's any family history of lymphomas, especially if it's a sibling, this would increase your risk as well. Typically, this disease is going to develop for adults between the ages of 15 and 34, and then also again at 55 and older. It happens more incidences of men than women, not by a huge margin. Last year it was estimated between 8,000 and 9,000 people in the U.S. were diagnosed with Hodgkin's lymphoma, and worldwide 635,000 annually. The cool thing is they've made a lot of advances in treatments for Hodgkin's lymphoma, and the 1-year survival rate is now at 92%. 5-year survival rate is at 86%, and the 10-year survival rate is at 80%, which for blood cancers is really, really good. It can be very treatable. Let's see. After your stem cell transplant, if you do the chemo and you go into remission and then you relapse and it reoccurs, and you have to have an autologous stem cell transplant, long-term remissions are achieved in about half of the patients. And if you don't get long-term remission from your stem cell transplant, your prognosis is actually pretty poor. Some of the symptoms that you would notice in patients that come in for their first diagnosis is going to be swollen lymph nodes, unexplained weight loss, fever that doesn't go away, night sweats, itchy skin. Your lymph nodes would be more painful after consuming alcohol, coughing, dyspnea, chest pain, and weakness and fatigue. So a lot of these symptoms are things that you can attribute to other things, and especially as a 61-year-old male, you can tell yourself, that you're just tired, and you work and do a hard job, and it just makes you exhausted. So a lot of the symptoms like weakness and fatigue is something that doesn't alert people right away that they might have cancer or that they may have relapsed, because that's stuff that you can explain away with other reasons. Other symptoms that you can expect when people come in and get diagnosed as hepatomegaly and splenomegaly. And when CBD, my patient, when he first came to the hospital, he experienced, not all of them, he didn't experience weight loss or fevers. He didn't drink alcohol, so he wouldn't have noticed painful lymph nodes after consuming alcohol, but he did have the weakness, the fatigue, and night sweats, and then he presented with liver, spleen, and lung involvement. So diagnostic tests and treatment. First, you're going to do a CBC. They're going to look for cell count abnormalities such as a high white cell count, blood levels that are low, anemia, things like that. You'll get a chest x-ray maybe to look for swollen lymph nodes in the chest area. You will definitely have a lymph node biopsy looking for the Reed-Sternberg cells. That's going to be your definitive test for diagnosing Hodgkin's lymphoma, which was how my patient CBD was diagnosed. There are rare forms of Hodgkin's lymphoma that have a cell called a popcorn cell. We don't get a lot of those. I'm not very familiar with that. Staging is done through your CT scans and your PET scans and bone marrow biopsies to see the extent of the involvement. And you can do an MRI, but it's not as helpful. And CBD, he had both CT and PET scans and a bone marrow biopsy to determine his staging. He was stage 4 when he was diagnosed. Staging the disease for stage 4, it's when one or more organs or tissues are involved, or an organ and distant lymph nodes from that organ are involved. Either one of those situations are going to put you at a stage 4. And then also there's another stage that they call recurrent for people that have relapsed. Their cancers come back. So since he'd already been treated for cancer and the cancer returned, he's now in a recurrent stage. He had a CT done of his neck, his chest, his abdomen, and his pelvis because of the night sweats. The CT unfortunately showed a 10 millimeter pulmonary nodule in his right upper lobe, partially calcified right axillary lymph nodes, borderline enlarged mesenteric and retroperitoneal lymph nodes, and a 10 millimeter liver lesion. Treatment originally was the 6 cycles of the ABVD. He went into remission. He relapsed. Instead of going straight for the high-dose chemo and the transplant, he went and did another 6 cycles of the ABVD chemo regimen, went into remission for 6 months, relapsed again. And then he did his salvage chemo, his ICE, and then came in to the hospital for his high-dose chemo, and which that high-dose chemo before transplants, the carmustine, etoposide, cytarabine, and melphalan. So he had that, and then got his stem cell transplant. And he got an autologous transplant, which means they took cells from his body, they treated him, and then they froze him in a preservative. And after he had his chemo, then they thawed the cells that they'd frozen and reinfused them. So that's where he's at right now. So as far as consults, one of the biggest, most important consults that we do for our patients are dietary consults. Once our patients have their chemo and their transplant, and they get this awful nausea and vomiting, and so it's really important to talk to a dietitian about foods that are easy on their stomach to digest. Like she's really good. Katie Lewis is the dietitian on our floor, and she's excellent, and she is gives great suggestions on foods that they can try to hopefully keep down. And then also as their counts, their blood counts and cell counts drop, which is what they need to do because we're trying to wipe everything out, then we hope that their new cells start to kick in and start making cells, and so they need to be educated about high protein foods to get their new cells multiplying and increasing in number. So we do things like protein shakes and stuff like that, and the kitchen at the hospital is actually really good about kind of catering to our patients because they have such a struggle with nutrition because they don't have appetites. The chemo changes their taste buds. They're nauseous all the time. It's it eventually does, they get relief from that, but it takes a long time, and in that time they really need the nutrition the most when they're feeling kind of the worst, so that their cells will come back and they will start to feel better. So currently, right now, CBD's counts are all at 0. When I left Sunday morning, his white count was 0.1. His absolute neutrophil count was 0.03, so they were almost to 0. And now we just wait for his body to kick in and start making new cells, and hopefully they're cancer-free cells. The big number that they like to look at is the absolute neutrophil count, the ANC. When it gets back up to 1,000 or 1.0, that's usually when they can discharge, as long as they're able to eat and keep food down, as long as they're infection-free, because at that point, when they don't have any neutrophils, they're most susceptible to catch any infection, which is why we kind of keep them up on our floor and keep them in a bubble. They need to be able to take care of themselves too, because a lot of times their stay is extended. They'll be there anywhere from 4 to 6 weeks, best case scenario, 4 to 6 weeks, and a lot of time they spend that in bed because they feel really rotten, so they can get deconditioned. And in some of our older patients who may have been very self-sufficient when they came in, after they go through all of the stuff that they have to go through to get better, they can be deconditioned and weak and not always able to take care of themselves, and so they kind of have to, before we can let them go, they've got to have somewhere that they can go. They also, if they live very far away, I forget the exact radius that they need to be in, some people can't go home. The first 100 days after their transplant is really crucial, and so a lot of times if they live too far away, over X number of miles away from our hospital, they have to stay at the Hope Lodge for their first 100 days until they get cleared of everything and make sure that everything's going to go okay, and that their blood counts are holding in, and that they don't need daily transfusions of blood and platelets and stuff like that. And with their immune system suppressed and compromised, we like to keep them closed, so that way if they catch an infection, they're here right away, where we can help and get antibiotics started immediately. So we do extensive discharge teaching when it comes to these kind of patients. Their whole life changes. I mean, I love taking care of my blood cancer patients. I find each experience unique and rewarding, but the disease, your heart just breaks for these people because it's so life-changing. And when they get diagnosed, usually, like I said, they don't have a symptom that's, just like a red blinking light, like something's super wrong with them. A lot of times they go into the doctor, just with a cough that won't quit, or just really tired. Sometimes it's the night sweats that bring them in, or, like the fever that they can't get rid of, nothing that would signify something major has happened to them. And so when they are referred to us, it's usually a pretty big shock. It kind of comes out of nowhere. A lot of our patients are still out in the workforce and still, productive members of society, and then, all of a sudden they can't go back to their job, and we pretty much have to start chemo immediately to get everything under control so that they start to feel better. And, some of these people have children and grandchildren that depend on them, that for safety reasons, to keep our patients, from catching infections, we don't let anybody, especially during flu season, under the age of 18 on our floor. And so for people that have to be on our floor for chemo and transplants for extended periods, to a lot of times not even be in the same city as their family, and then they can't even come and visit. It's really difficult, and it's very overwhelming. What I love about CBD, and he doesn't have small children, his children are adult, which makes things a little bit easier for him. But he had the best attitude, and a lot of times when all this stuff kind of comes crashing down on our patients like a ton of bricks, they get very depressed. and just, very withdrawn. They're taken away from all the people that they love. Sometimes those people have to work to help pay for, the things that they need and pay bills and, keep everything going. And so they can't always drive every day to come and visit, and it's not always feasible. So a lot of times people get withdrawn and they get very depressed, understandably. And it is so overwhelming, they don't have time to absorb what's happened to them before they're being treated with chemo, and they're just overwhelmed. And I think just the coolest thing about CBD is from the first night that I had him as a patient, just very upbeat, very hopeful, had a great attitude, which is really important to his success, because people like that, they are determined, and that kind of determination to their success it's going to lead to a shorter stay in the hospital. It's going to lead to them getting better faster. The people like him are the people that force themselves to eat when they're not hungry and when things don't taste good, or when they're nauseous. They're the people that, even though they're super tired and worn out because all of their counts are low and it just makes them feel like junk, they will force themselves to get out of bed and walk in the hallway and keep their strength the best they can. They try to do as much as they can for themselves, with their ADLs, and keep as much of their normalcy as they can, still watching the basketball games on TV. And CBD just has the best attitude, and I love that about him. He's hopeful, he's positive, and attitude is everything, because it doesn't end when they're discharged. When they get discharged, they'll either go home if they're close enough, or they'll go to the Hope Lodge, and they do very regular visits in our outpatient clinic. They usually typically start out 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, and depending on what their transfusion needs are and things like that. So they're still at the hospital all the time. They're just outpatient at that point. And then even beyond that, like when they go home, they have to change a lot of the things that they do. They can't go to a fast food restaurant anymore and just go to the drive-thru and get a Coke if they want it, because the spigots have too much bacteria and they're not cleaned well enough. They can't go to Kroger and pick meat up from the deli, because the deli slicer, the meat slicer, it's not cleaned well enough and there's too much bacteria. They have to have their foods completely cooked. So if you like your steak medium, now you're going to have it well done, which if you're a steak eater and you like it medium, no more steak, which is too bad, because that's a great source of protein. Not using dish towels in your kitchen anymore. Now you have to use paper towels, because the dish towels, they get so dirty and they're not washed often enough, and we might wipe the counter off and then wipe our face with them or our hands with them. And you can open up your fridge if you're like me, and you could probably pull 10 things out that are probably expired, because we don't think about that stuff all the time. But patients like this need to be hyper vigilant about stuff like that, because the slightest bit of mold can make them really sick. Even when their neutrophil count comes back and it's at 1,000 and 1,500 and it starts to climb, their immune system is still never going to be the same. It's always going to be harder for them to bounce back from illnesses. So let's say if they get the flu, like if I got the flu, I'd go and I'd get some medicine and I'd ride it out. And if they get the flu, they're going to be in the hospital for a week or 2 weeks on IV antibiotics. It's just not, their whole life has changed from this point on. So you don't ever get to go back to normal. So when I find people that are like CBD, that are super positive and super upbeat, it gives me a renewed sense of hopefulness for him and for patients like him. His attitude changes my attitude. And I think you'll find most of the nurses, at least on my floor, will tell you that the patients do more for us than we ever do for them. To watch them go through this transition and these diseases, the blood cancers are just horrific to deal with, and to watch their determination and their grit and their just the way they just keep plugging when everything is terrible and the diarrhea is eating at their skin from the chemo, and they're throwing up all the time, and nothing that they used to like to eat tastes good anymore, and they can't see their family, and it is so overwhelming, and to find patients like CBD that have this attitude, it makes all the difference. So that's all I have to say about Hodgkin's lymphoma. I'm sure that was way more than anybody needed to know, but I'm passionate about my job and I love it. So I always have probably too much to say.